Dr. Maya, and my dear friends in IAP. It's a great moment for all of us when we are having an oration in connection with the Silver Jubilee celebrations of Child Care Center run by IAP Kochi. As in we had the inaugural function on Sunday when we saw Dr. Abraham K. Paul presenting the report on Child Care Center, and it has become a center of excellence for children with the disabilities, and also an excellent center for newborn hearing screening program. And it has become a model for not only for India, also WHO has adopted it as the model for South Asia region. And congratulations to the committee that is running, the management committee that is running the Child Care Center, as well as the IAP Cochin branch. And this week, IAP Kerala is observing as Disability Awareness Week. So we had the programs from the Sunday of this week, and today is the 5th day that we are having programs related to disability awareness. And today we had more than 3 programs at different parts of Kerala. And during these 5 days, we could touch upon most of the areas of childhood disability. And also the public were involved in the program. So I congratulate all the branches for doing that. And today we have a speaker, Dr. Samir, who is the doyen of developmental pediatrics in India, an office bearer of neurodevelopmental chapter of IAP, and a good friend of all of us in Kerala. So with these few words, I wish this program all success. Wish you all happy learning. Thank you.
Thank you, Dr. Narayanan. Next, I invite Dr. Abraham K. Paul, Executive Director, Child Care Center, to say a few words.
Good evening. As you know, today, December 3rd, is the World Disability Day. And as Dr. Narayanan said, IAP Kerala had a week-long program. And incidentally, we at Child Care Center are celebrating the 25th year of its existence, and the Center for Learning Disabilities. And we could help about 20,000 children since the inception of the center in 1995. And as part of the celebration, today we have an oration on learning disability. And the highlight is that we could get the right person, Dr. Samir, to do the job. And he will be introduced formally by Dr. Maya. In fact, he is a multi-talented, and excellent committed developmental pediatrician. And I am sure you must have seen him as a debater in the national channels on various issues related to children. And he has a very good liking for Kerala, especially for our dish, crab. So I have offered him that whenever the COVID pandemic is over, definitely we have a great occasion at IMA House. Actually, now we got a 5-star facility at the IMA House now. So I am sure Dr. Samir will definitely enjoy your hospitality at the new premises. And thank you very much. Thank you, Samir. Thank you.
Thank you, Dr. Abraham K. Paul. Now we will straight away go into the oration, and I invite Dr. Maya Bose, who will be chairing the session. She has done her MBBS from Kasturba Medical College and further training in pediatrics from University of Melbourne. And she has worked in Singapore, and then later in the US, she has done her, she's a board certified pediatrician, and she's also completed a 2-year fellowship in integrative medicine from University of Arizona. After 10 years of stint in the US, she's moved back to Kochi, and she's done her IAP fellowship in neurodevelopmental and behavioral pediatrics from CDC Trivandrum, and currently working as developmental pediatrician at National Institute of Physical and NIPMR at Irinjalakuda. Over to you, madam. Thank you.
Thank you, Dr. Pramod. I hope everyone can hear me.
Yes.
Yes, audible.
Okay, as mentioned earlier, today is the 6th session of IAP Kerala's Disability Awareness Week, and the most awaited one too. It's really an honor for me to introduce Dr. Samir Dalwai. As you all know him already, there's no need for introduction. He's just phenomenal, both as a developmental pediatrician and as a person. In fact, for those of you who don't know, he's also a graduate of law. So there are many hats that he wears. There's a lot to his credit, and almost all of it is worthy of mention. So I'll just go through quickly. Dr. Samir is a true visionary, which is evident from the impact he has made in all the roles that he has played. He's a founder of the New Horizons Child Development Center in Mumbai, and he has expanded to 5 of the state-of-the-art multidisciplinary centers, one of which myself and Dr. Susan has visited last year. He's a secretary chairperson of IAP Childhood Disability Group since 2010. She's also founder and chairperson of Neurodevelopment Chapter. He received Best Chapter, in fact, the Neurodevelopment Chapter received Best Chapter Award in its first year itself. He's the founder chairperson of IAP Fellowship of Developmental Behavioral Pediatrics, which I too was trained in. And he has mentored many developmental pediatricians and centers all over the country. He also conducts the same fellowship in his center. He's one of the important.
He's one of the important brains. You can hear me, right? I got a call in between. You can hear me?
Yeah, yes, Maya, you're audible. Yes.
Okay, I can hear.
He's one of the important brains behind IAP guidelines on ASD, ADHD, LD, newborn hearing screen. It was published in 2016-17. He also worked and proposed a theory of social interaction in autism spectrum disorders. He is a recipient of Rajiv Gandhi Manav Seva Award in 2012 for service to children. He is the National Joint Secretary of IAP in 2020-21. He was a past president of IAP Mumbai as well. He's a visiting consultant in Nanavati Super Specialty Hospital and Hinduja Hospital. Above all, he's a wonderful person and he's a great orator, so we all be waiting to hear him. Please join me to welcome Dr. Samir Dalwai. And today is the Child Care Center Silver Jubilee Oration on Learning Disability. Over to you, Dr. Samir.
Namaskar and good evening to everybody, and good evening to respected IAP Kerala President Dr. Narayanan sir, respected Dr. Pramod Warrior, President IAP Cochin, respected Dr. Bal Chandraji, Secretary IAP Kerala, Dr. Sajid John, Secretary IAP Cochin, and of course respected past President of Indian Academy of Pediatrics Dr. Sachidanand Kamath, my dear friend Dr. Abraham Paul, Executive Director of the wonderful Child Care Center, and Dr. Jason Undi, my dear friend, as well as chairperson of our chapter, Dr. Randava, who's my executive board colleague, all my other dear friends, like you mentioned rightly, from Kerala, wonderful people, wonderful friends, many, many wonderful memories. I am humbled by this gesture of yours to have awarded me the oration on the prestigious 25th year Silver Jubilee celebrations of the Child Care Center, because ever since we started working in developmental pediatrics, way back in 2003, I would only hear of what work was being done in Kerala. And today I must say that it has been an inspiration of what work has happened in Kochi specifically and in Kerala in general, that has been the cradle of developmental pediatrics in India. And we are grateful to all of you. And I'm very humbled that on this occasion, on the World Disability Day, you have given me this opportunity and you have blessed me with this. So thank you very much. Please allow me to uh, begin with my presentation on the topic. So the great work that has been done in the Child Center in Kerala, I think it's amazing and we must learn from it. And hence I would always say that I would like to dedicate today's orations to the Child Care Center Kochi per se, and also to Dr. M.K.C. Nair sir, who, like me, many of you are fortunate to have been mentored by him to continue to receive his love. To Dr. Sachidanand Kamath, my elder brother, my mentor, and the person who brought me into Indian Academy of Pediatrics. Dr. Abraham Paul, again, who's like my elder brother, who has helped me, coached me, mentored me. And Dr. Jason Undi, again, my very dear friend and a brother, because these were the three gentlemen who initiated me as secretary into the Childhood Disability Group in 2010. And whatever I owe in my work in IAP and development pediatrics is to the free hand, the support, the encouragement and the guidance that these three gentlemen have given me like a brother all through the last 10 years that I've been fortunate enough. So thank you and namaskar to all of you for that. Going ahead, I'd just like to present a matter that all of us often see. Now what happens is, the debate that I was having a discussion with Dr. Maya also today. The whole idea about developmental pediatrics is that it should not be restricted to developmental pediatricians or to neurologists or to psychologists or to therapists. Developmental pediatrics is not for the developmental pediatricians or specialists. It is for the pediatricians, because the most fundamental basic role of a pediatrician is growth and development. And development is the most fundamental role of a pediatrician. Unfortunately, when we talk too much about neurodevelopment, we take it away from the basic pediatrician. And we are doing a great disservice to the person, the child who needs developmental pediatrics, because that can only be provided by the pediatrician in India. And hence we must strengthen the hands of the general pediatrician, the regular pediatrician who sees the 100 million children in India that we have under IAP. And hence I'm going to base today's oration on how we can strengthen the hands of the general pediatrician to deal with the situation, irrespective of having whether any developmental pediatrician, neurologist, psychologist, therapist, special educator, whether they are there or not there. And I will explain how that can be done. Anita is a 10-year-old girl studying in a good school in grade 4. She's brought to any of you as pediatricians with simple complaints of avoiding school, began lying to parents, even stealing money from home for the past 2 months. But 6 months ago, she was caught signing her own report card without letting her parents know. The parents noted that when they caught her after that, they have noticed her to be very quiet and aloof and withdrawn. Now, 1 year back, when you ask for the history, the parents do tell you that yes, there was some story before. First, they say it's only 2 months. Now they say no, 1 year back, teacher had told that she's making many spelling mistakes. That was in grade 3. And she had difficulty reading her class 3 books. Even before that, there is a history. And hence, when we say ODP, this is the first mistake that we make. Because ODP does not apply to developmental pediatrics. Because ODP of developmental pediatrics is developmental history. And hence the real history starts with birth or before birth. So here earlier again, the parents said that the teachers had told that this had happened many times, that they had been called and told about some academic complaints since grade 2, and the behavioral other complaints have only come after grade 3 or grade 4. And they also report that she remains lost in her own world since the last so many days. So going ahead, how do we realize this? Why had the parents not responded at that time when they were told about this? This has been brought to their notice. Why have they not done anything about it? They said that she had done well in her pre-primary. In junior KG, in senior KG, Montessori, she was very good. And they thought she will gradually pick up because her birth history and early developmental history were normal. And I'm sure all of you who have worked in this field will have had hundreds and thousands of children like Anita. And when you examine these children, you don't find anything wrong with the general examination or systemic examination. But when you notice her behavior, she looks dull, demotivated. But when you talk about dancing or movies or singing or art or sports, if it is a boy, suddenly they will brighten up. And then the moment you bring the topic to her behavior and to studies, she starts looking anxious, withdrawn all over again. Head circumference is normal, skull, spine, skin is normal. All other findings are normal, no focal neurological deficit. And hence, the message to my dear friends is, how do I as a pediatrician suspect and recognize learning disorders? How do I deal with this? Why should I deal with it? It's not something I can understand. And hence, to understand, we must realize that if a child is not doing well in childhood or at school, then there are two parts. Either the child does not seem to learn or understand most things of daily life, does not understand to get up, to greet people, where to sit, what to do. If you send her to the shop to get something, she will not understand that. If you tell her to her neighbors or neighbor's place, she will make a mess. So she is not doing well in anything in life. Or on the other hand, you have a child who does understand most things. In fact, is very good at all these things, can go to the shop, get your household done, work done. If there are some guests coming to your house, she can help you take care of them. He can go to the neighbor's house and charm all of them, but poor only in reading, writing and math. And hence, dear friends, this is the first distinction that we must make about a child who comes to you with these complaints. Is this a problem of daily life or not of daily life, only of reading, writing and maths? So the question you will ask, is Anita good in her activities of daily life? And if they say no, she's not good at all, she's not good in all these things, she's not able to handle her day-to-day life at all, she cannot go to the neighbors, she cannot go to the shop, she cannot manage things at all, then I have a small chart for you that I'd like you to go by one from the left. How do you approach this, dear pediatricians? First, did she have a significant birth history? Is there any antenatal problem? If yes, rule out hypoxic ischemic encephalopathy and birth injuries. That could be the reason why she has an overall problem. Does she have any dysmorphic features? Does she have microcephaly? And yesterday we had this wonderful presentation day before by Dr. Jason about Down syndrome, and his team spoke about it. So if yes, you have to rule out genetic abnormalities. Does she have global delayed development? Does it mean that she had delay in all the domains, gross motor, fine motor, social, speech, communication? If yes, then you rule out something like an intellectual disability. Or did she have delayed development only in specific domains, like maybe only the motor domain, all the other domains were normal, or only maybe in the social communication domain? Then you have to either rule out neurological or muscular disorders like muscular dystrophy or congenital myotonia, or a hearing disorder or a visual disorder that Dr. Paul has worked on hearing disorders for so many years now, or a condition like autism. But if you have a chronic general condition that most pediatricians are used to, do you have malnutrition, chronic infection, tuberculosis, epilepsy, post-meningitis, the child has hydrocephalus, or hearing loss, severe eczema, and history of absenteeism from school, rule out chronic debilitating conditions like progressive neuromuscular disorders like adrenoleukodystrophy or other issues or tuberculosis, which may cause this child to have overall lagged behind in her life. Because these are things which are completely within the purview of a general pediatrician, and we should be able to deal with this. Now, if Anita was good in her daily activities of daily living, she is smart in everything else, but has only a problem with her reading, writing and math in school, no other problems, then it's a totally different etiology that you have to look at. And if she is good in general activities of life, then I urge you to ask 3 questions. 3 questions will help you understand where the problem is. First question, how is her attention span? Is she impulsive? Is she hyperactive? Second question, how is her mood and how is her motivation in life? Third, does she show consistent patterns of errors in her reading, writing and math? So now this is a child, I've given you the history earlier. All the earlier issues of being poor in overall life have been ruled out. She's very smart in everything else. They gave you the history. So now the questions are about her attention span, impulsivity, hyperactivity, about mood and motivation, and about consistent patterns of errors in reading and writing. And we'll come to that one by one. So when you ask how is her attention span, impulsivity and hyperactivity, if there is a problem with that, we must understand that we are looking at something like an ADHD spectrum. And children with ADHD are unable to learn since early childhood, since they do not pay attention or complete activities that they have to be learned. And hence, they suffer from poor social acceptance and worsening academic performance right from the beginning. And hence, if you go back in the history of poor social behavior will be before the history of worsening academic performance. The mother will say that he always was a troublesome fellow. And now he has had a trouble only also in academics. So the history of social behavior problems will precede that of worsening academic performance. In earlier classes, please remember about ADHD. Since the academic content is not much, these children can pick up with even a smaller attention span. That's why their academics earlier on does not suffer. But as academic content becomes more complex, the attention span falls short and they begin to lag behind. So if it is a behavioral complaint earlier, now a complaint of academics, it's more likely an ADHD child that you must keep in mind. Going ahead, the next question, how is the child's mood? And here I've drawn you a chart. Please understand that children who have poor social behavior, poor academic performance, they are not accepted. There is a chronic lifetime history since the last 4 or 5 years for even this child. She was ignored, she was either neglected by her teachers, insulted by her classmates, abused maybe by the parents, by the other parents of other children. No one seems to understand or accept the child because this child is always getting into so-called trouble with others. This leads to poor social acceptance, and social situations or examinations bring out the worst in the child. There is worse anxiety, worsening self-esteem, worsening confidence. And I'm trying to bring in that it's not only about reading and writing or about hyperactivity. It's all about emotion and mood. And this worsening self-esteem, poor confidence, anxiety further leads to isolation, and further the child withdraws from participating anywhere. And that leads to a withdrawn, sad, depressed child. If it goes unchecked, year after year, further damage, poor marks, further insults, further ignoring, further abuse, it may even lead to suicidal ideation over a period of time. And this is extremely important. This is a thread that is running through the beads of poor marks. You will focus only on the beads, but I would urge you to focus on the string that passes through these beads, making it a deadly necklace around a child's neck. And hence, what is important to understand is how is their motivation. Lack of motivation to participate or to attempt anything, because now the child gives up attempting to study, even gives up attempting to be good. This is what is withdrawn, and this now becomes the biggest hurdle to any intervention. This child may come to you, you may diagnose as learning disability, and you may start with remediation, as I was talking to Dr. Maya this afternoon. You may have the best remedial educator so-called in town, but it will not help because the child is demotivated to do anything. And though it was a learning disability earlier, it will not help now because now the problem is demotivation. Unfortunately, parents think this is nothing but lack of interest. When you say lack of interest, you cannot do anything about it except give big pravachans and bhashans which further irritate the child. And when this parent comes and tells you, my child is lazy or lack of interest, you tell her lack of interest or otherwise is in the bank, not with the child. What you are seeing is lack of motivation, and correct the parent to understand the right language. It is not lack of interest, it is lack of motivation to do that particular thing. And hence, when you know that, lack of motivation can be worked upon by explaining to the parent that they have to find out and accept the child's weaknesses. Don't focus on the weakness, but focus instead on the child's strength. Encourage everything that the child attempts and praise the effort, not just the result. So even if the child is good in singing, if you want to motivate her for studies from which she is demotivated, first encourage her for her singing, for her dancing, for her art, for the good things she does for the grandparents in the house. That will bring her motivation back into everything, including academics. And hence, these are the few things that we must look for. But having ruled out ADHD, mood problems, motivation, now it comes to us to look at specific patterns of errors in her reading, writing, and math, in spite of normal intelligence. How did you know she had normal intelligence? Because she's good in all her general activities of life. So largely general intelligence is good. And there is good vision and hearing, you have tested for it. That is when now you must narrow down on learning disability. And here the child shows specific difficulty, specifically in reading, writing, and maths for her grade level. She may be able to read class 1 or class 2, but she's not able to read grade 3 or grade 4. And very important to understand, there is a consistent pattern of errors. The kind of errors she's making are very consistent in a particular pattern. So she may read hesitatingly, she may stop and she may guess, she may make lots of errors while reading. She guesses the sight word, she may just read the first 2 alphabets and she may guess what word this is. She may skip words that she does not understand or he cannot read at all. She may skip entire lines. Obviously, you see her fumbling and very nervous and shivering while reading. You see the change in her voice, and she will make every excuse to avoid reading. The pencil will drop down at that time. She will say she has to go to the toilet. This is a pattern. Every time you ask the child to read in front of you or in the class or at home, the same things will happen again and again and again. And hence, don't focus on one or two symptoms. Focus on the facts that there is a pattern of symptoms. That is very important to understand. And hence, just to show you this kind of sample that I have from our center, you will see when you look at the child's book, you ask the parent to come to you with the child's notebooks, not the textbooks. Textbook is for reading, the notebooks where the child has written. And when you go through, don't just look at one page, look at 4 or 5 pages, look at 2, 3 different books. What are you trying to see? You are not trying to find one mistake. It's not like that you are going to find one petty K. You are going to find a crop of petty K. It's a pattern. So look at a pattern of errors. There could be an error of punctuations. There could be omission. The child has omitted one particular alphabet. Or there could be an addition of an extra alphabet or a letter. Or there are errors of spelling the child spelling phonetically as it sounds. These are all typical errors of what we call dyslexia of reading or spelling. Again, not being able to write within the lines. Can you see this part here? Half the words, alphabets are above the line, half of them are tumbling down as if somebody has pushed them down. You look at the uneven pressure on the writing tool, that is a pencil, while writing. Look at the uneven shapes and sizes of the alphabets. If you look at even S, you will find difference in the S at different places on the same page. You look at A, you will look at different, you will see a different size of A at one place, different size of A in another. All these are typical errors of how the child puts the handwriting on the paper. And that is typically dysgraphia, the errors in the child's shapes and sizes and patterns of writing. Similarly, going ahead, some more examples of uneven pressure on the pencil while writing, uneven shapes and sizes of alphabets. Again, dysgraphia, omission, errors of omission, errors of addition, mirror image when you are writing. All these are errors of dyslexia. So these are various examples, and if you go through the child's books, you will find it in every subject, because the parent might tell you, no, this particular teacher is not good. So she makes errors in this teacher's subject. If that was so, the other books would be perfect. But if you look at it as a pattern, you will find the same pattern of errors running through all the notebooks. And this is a simple exercise, all of us can do that. You look at the various, the size or the shape being different everywhere. Look at the errors of punctuation. Half the alphabets are above the line, half are below. Some words are written very dark with a lot of pressure. Some are written very light. Even look at the issue here. There are so many errors that you can point out in. And it's not difficult once you start doing it. And hence, when you get a consistent pattern of error in reading, writing, and math, in spite of normal intelligence, good intelligence, vision and hearing being normal, she makes errors of patterns of addition, omission, the size and shape of alphabets, writes with too much or too little pressure.
Dr. Samir, you're breaking up.
Do you hear me?
Yes.
Yes, sir.
Yeah, I think I just lost connection. Just one moment.
Yeah, it's all right now. Yeah, continue, Samir, but unmute.
Are you able to see the screen?
Yes, sir. Yes, sir.
Yes, yes.
Sir, it might help if you switch off the switch your video off.
Yeah, sorry about that. So So similarly, even when it comes to simple addition, simple subtraction, multiplication, division, carry over from one page to the other, word sums, copying numbers from one page to the other, you will find a consistent pattern of error in this child. So as a pediatrician, all that we expect of you is to find out if there is a pattern like this that's happening, in spite of the child being average or above average intelligence. Then simple evaluations like we spoke about, take the entire history to rule out any other problems that we spoke about earlier. Physical examination we spoke about, neurological evaluation is important, very, very important, objective testing for vision, hearing and intelligence, and that's where you need to send to a pediatric ophthalmologist, you need to do an audiology evaluation, you may need to send to a psychologist to do an IQ evaluation to make sure that the child's IQ is normal. You may need to test for the child's attention span and hyperactivity. You need to test for age appropriate reading, writing and math achievement. So you can send to a psychologist or special educator, or you can ask the mother to bring the child's class books. If the child is in class 4, see whether she is able to averagely read what is her book. If she is not able to read class 4 well, ask her to bring a class 3 book. Ask the child to read a class 3 book. See how much better she is able to read class 3. If not, try a class 2. If you are able to show that the child is able to read class 2 very well, grade 2 very well, make sure you tell the parent for some time wait and focus on teaching the child to read correctly for class 2. Then focus on making the child read for class 3. Then go to class 4. So it's very important to understand that no great special educator can teach a child to read about class 4 unless the child is able to read class 2, class 3 and class 4. And hence it is not about special education or remediation only. It is about the child being able to read step by step what she has not been able to learn on her own. And this is something that the pediatrician must ensure. So you may not be an expert in remedial education, but you are obviously an expert to understand that a child should first sit, only then can the child stand, only then can the child walk. So the child should first be able to read very well standard 2, only then will she be able to read standard 3 and standard 4. So even if you have referred to a remedial educator, please call the child to your OPD every month and monitor whether the child is now reading class 2, then class 3, then class 4. You do not need to be a remedial educator to do this. And you should not outsource this to the remedial educator. It is our job. And you can charge the child for this. You can call the child to your OPD for this. It is a valid consultation because you are the one who's going to monitor this in the child's family. And hence everything is step by step, whether it is reading, writing or math, it is in your hands and management is in your hands. Medications have a limited role, and we have heard Dr. Jason talk about it so many times so well. For ADHD, you may give methylphenidate or atomoxetine as a stimulant, non-stimulant. For anxiety and depression, we do use a lot of fluoxetine. If already the child is 8, 9, 10, 11, 12 years old, has suffered all that I explained to you about mood and motivation, you may need to worry about her anxiety and start some medication. But if you do not speak to the parent, if you do not counsel the parent, it will not help. Nutrition and diet have a very, because malnutrition, anemia, failure to thrive, specific deficiencies can definitely worsen the child's academic performance. Again, your role, dear doctors, as pediatricians, to deal with this. If there is a visual and hearing impairment, you are the person who needs to pick that up. And hence, you are the one who understands overall what the child needs. The child may have a specific learning disability, the child may have an attention deficit, or the child may have an hyperactivity component. The child may now have developed anxiety and a low mood or depression. The child may be demotivated. You are the one who's going to counsel the parents that, look, unless the child's mood gets better, no amount of remediation is going to make the child better. If the mood is better by counseling the parents, helping them to deal with the child, accept the child better, all that we discussed, that's great. If not, you may even need to start a small dose of fluoxetine. If the child's hyperactivity gets better by allowing the child to play more on the playground, great. If not, you need to think about starting either methylphenidate or atomoxetine, because only these things will lead to a comprehensive improvement, not just about focusing on reading and writing. Please remember this. At our center, I'm sure at the child care center, there is a team-based holistic program developed for each child by a developmental pediatrician, along with a clinical psychologist, occupational therapist, remedial educator, counselor, social worker, and collaborating with the child's school. And hence, a pediatrician is the person who has to counsel the parent what is the role of all these areas in terms of getting the child better? Not just to send up a child to these people, but to explain to the parent how the child is showing improvement. So you have to be able to monitor the child's improvement. And sometimes there's no point, the poor mother has tried her best, but the mother-in-law, the father-in-law, the husband may not understand. So you need to call all of them. It's your word that matters the most in supporting the mother for this. And there are also boards which offer educational provisions. I'm sure the State Board of Kerala and Maharashtra and many other states offer that. Alternate NIOS is offered. You need to tell the parent this. So finally, what are the take-home messages? Unidentified and misinterpreted. He is not studying because he is lazy. He is disinterested, not interested. All these are mistakes. These mistakes can lead to demotivation and various psychosomatic disorders in children. All neurodevelopmental disorders are a combination, are beginning with neurology and genetics, but they have a very big environmental role. All learning disorders are a group of conditions which affect the child's ability to acquire new skills and successfully adapt to the environment. And hence, an entire neuropsychological analysis is of most importance in the management of children with NTDs. Similarly, when it comes to learning, it is not only learning disability that affects learning. It could be poor physical health, it could be nutrition, it could be poor IQ, it could be attention deficit, it could be a hyperactive, poor self-regulation, poor mood, poor motivation, in addition to socio-economic cultural factors. Specific learning disability is only a small group within this, in which the brain is unable to decode, interpret, process, or express the skills necessary for reading, writing, and arithmetic. They cannot decode, interpret, process, and express only the skills necessary for reading, writing, arithmetic, for singing, for football, for music. All that area of the brain is perfect. And dyslexia, dysgraphia, dyscalculia are three such examples. And hence, pattern of error needs to be identified to diagnose specific learning disability. So to summarize, we believe at New Horizons, disability exists in the mind of the person who thinks another to be disabled. If I remove this, I may not be able to read, I am disabled. Instead of calling me disabled, the person who invented this, the frame of glasses, he was the more important person. Thousands of people call me disabled because I cannot read. The person who made these glasses actually did not think like that. He did not call me disabled. He enabled his own brain to think of something that can enable me. So before I call somebody else disabled, I need to use my own brain. How can I solve his problem? Because if I cannot solve that other person's problem, the disability is with me, not with that person. We must have that attitude. That is what I have learned in my 18 years plus at New Horizons Child Development Center with thousands of children. It's been a pleasure on this wonderful journey. And with this COVID, we had this again another amazing opportunity to come out with an online support services. And I have been blessed to have the support, love, and affection of all of you in this journey. So thank you once again from the bottom of my heart. Gratitude to all of you. Thank you so much.
Thank you, Dr. Samir. As always, your talk gives a different perspective to the problem. And to re-emphasize the take-home messages, what we all need to be aware is that a child presenting with learning disability or learning difficulty, I should say, is not being lazy. He might have a lot of underlying problems, and it's important to be aware and look for it and intervene early. Are we looking at questions or? So Dr. Pramod asked, how is online classes affecting motivation? Oh, it's from another person, Ashok Kumar.
Sorry, do you want me to answer that? Dr. Maya?
Yes, I thought we are not taking questions because today's an oration.
Yes.
But maybe just a couple of questions and then we can wrap it up.
Yeah, so what's the question?
How is online classes affecting motivation of children?
Yes, because we must understand school and education is not about only reading and writing. It's about the company of friends. It's the interaction with each other. It's the learning from the teacher. It's the environment. There are some children who love that part of it more than just the reading and writing. They are missing all this in an online environment and hence they are demotivated for that. But I love the fact that whoever asked the question asked about the word demotivation. That tells us that we are on the right track. So we need to find out what exactly is demotivating the child. Here he is demotivated by he's probably missing the physical presence of all that. Parents can do one simple thing. After the class is over in the evening, they can make a phone call, put 2-3 children together on a video call and get them to talk to each other and share their stories. That will make them happier and take more interest in the online learning as well. Thank you.
Just one more question, Dr. Samir. Someone has asked, Divya has asked, what will be the final outcome of reading and writing skills of these children? I guess it's a question about prognosis, and also if it's hereditary. Is it possible that it will be repeated in the siblings?
Yes, we know that these are genetic issues, so there is a high chance of it being repeated in the siblings or in the family down. Very often one of the parents has had this similar problem. The final outcome, this is a question I always get asked by people. What is the final outcome of a child with autism or ADHD or about learning disability? The final outcome depends on you as a pediatrician monitoring the outcome every month. Let me be very blunt about this. The final outcome, nobody has a right to ask about the final outcome unless you monitor the outcome every month. We tend to refer children to therapists, to special educators, to psychologists, and then we want to know the final outcome at the end of 16 years. That's not fair at all. Every time you refer a child, call the parent back to your OPD. If you don't feel you should charge, don't charge. Every month ask what was the outcome. Is your child better at reading today than he was last month? Is your child's social behavior better than last month? Is your child's communication better than last month? If not, call up the person to whom you have referred and take them to task. Ask them what is going wrong. It could be because they are trying their best, but the child has another comorbidity that you have missed. Then if you need to look at a comorbidity like an ADHD or an epilepsy or maybe malnutrition, you can change that. Then the next month the outcome should improve. So the outcome of every child, and I will quote this on camera, is infinite, provided you work on the outcome every day or every month. That's my answer. And that's my experience.
Thank you, Dr. Samir. We discussed this briefly in the afternoon also, that we need to take responsibility and not just, outsource these children to therapists and special educators. It is our responsibility, our patients, so we follow them up. Thank you very much, Dr. Samir, for today's oration. I'm sure it was very enlightening to everyone. Is there any other formalities left, Dr.
Samir? Thank you, Dr. Maya. I request Dr. Sachidanand Kamath, President 2015 IAP, to say a few words. Sorry, I missed him in the beginning.
Thank you, Pramod. Excellent talk by, as usual, by our dear friend Dr. Samir. You have taken us a journey from just a topic of learning disability to a poor scholastic performance. That is the basis behind this talk, and I could go to that. The pediatrician is the pivotal role for everything, and we are the person, that is the pediatrician, who are to be looked after. That is the emphasis you have given. That is the message you have given. That is the thing behind all this presentation, to give a message that we as a pediatrician should know and to take the lead to come, and the parents also will be more comfortable with the pediatrician rather than to a special educator or psychologist or psychiatrist or any other. But we need the multidisciplinary approach, as Dr. Samir has told just now. Excellent talk, Dr. Samir. It is well orchestrated, that such a way that it is led to you that from the just a person, that is just one example you have gone through, that how a child can be looked into a poor scholastic performance to a level, that how a pediatrician's role to a poor scholastic performance, including learning disabilities, and to rule out other causes. Very good, very informative. Thank you, Pramod, to giving me an opportunity. Thanks, Dr. Samir, well appreciated. And you can see in the chat box also, well appreciated.
Dr. Pramod, can I make a comment?
Please do, sir.
Thank you, Samir, first of all, for boosting moral of all the pediatricians that you can do something. Traditionally, we are not usually during our part of training during post-graduation days. And in the first, I think 10-15 years of my practice also, I used to ignore these patients with these complaints. Then slowly and slowly I learned that spending more time with them is very, very useful and beneficial. In my area, mostly my receptionist, she writes down that poor school performance, these are the chief complaints, right? Whenever I see a slip, then if mother is very tense, I usually postpone the counseling or consultation. I always ask her, if you have more time, you come during post-lunch period, we will sit together and discuss, and bring a person with whom the child is most comfortable. Because the moment you ask mother, what are the complaints? He doesn't do this, he doesn't do this, he doesn't do. Then as in handicap, we have stopped using the word handicap and we call them as differently abled. I start with what are the best strengths in your child. You tell me the positive points. We will discuss the negative and threshold the negative things later on. You tell me the best thing. Whenever she says I don't, he doesn't do, I always offer him a paper and a pen and tell her, you draw my sketch, I am sitting in front of you, right? And obviously there is hardly 1% who are blessed with that that they can draw a sketch of someone sitting in front of you. When she is not able to do it, then I tell her, are you disabled or differently able? She says, no, I am so and so, I am a civil servant, I am a banker, I am so and so. Then probably she understands my concern that we have to approach them in a different way and look for the strengths. It has really helped me a lot. And you have stressed this factor that common pediatricians need to be in the loop. And we are the blessed one. Even till date, ours is a specialty which families believe the most and sincerely. And most of the specialties, they are losing people's faith, but pediatricians, we have the longest possible contact with any particular patient, right from birth to maybe till 18 years, then probably then he gets married, he bears children, again we start having contact with the families. Thank you very much.
Thank you, sir. Thank you very much. I request Dr. Jason Unni. Dr. Jason, sir, a few words.
Samir.
Yes, sir. Hi.
Brother, you've done a great job. No, I appreciate Samir for being, a developmental pediatrician and only that. If we're doing a mixture of everything, like Maya is doing only developmental pediatrics, suddenly Maya. Susan is doing that. There's a lot of we're so fortunate to have so many pediatricians doing only development pediatrics. And that is what has made this IEP neurodevelopment chapter such a vibrant chapter. They're so focused. Anyone doing work with children, differently able children, are so passionate about it that they will go to they'll not let a stone unturned to work for them. And the PWD ministry, we had a few people who were so passionate, even Joe Rosario and all of them were so passionate about differently able children. That's how passionate our group of pediatricians who are doing work in development is. Samir is one of our leaders. He's done a fabulous job. 5 centers in Mumbai. I used to wonder how he's running. So he's run around from one center to the other, and he's got a queue of almost all the patients who come there. He ensures that every person working for him reports to him, and he's the one who sets goals and monitors these patients. That is quite an effort, because most of us pediatricians, we send it to a therapist or somebody, and then we don't really follow up because we don't have the time. If the patient comes back to us, report, fine. But that's not what should be done. I think what Samir has said all through his talk is that we as pediatricians and development pediatrics need to follow up these children on our own. We must know what the goals have to be set. We should know what exactly should be done at a particular time for that particular patient. Every child is unique, and every child has to be set a goal and set a therapy that is unique for that child, and that every pediatrician should know something about it. And that's what Samir has been always emphasizing, that we should not let ourselves be considered as a referral center. We have to be the person who's in charge of this patient. Samir, I hats off to you for all the work you've done and the motivation you have given to a lot of people. I think you've been a motivator for very many, isn't it, Samir? There are a lot of people who have joined this whole bandwagon because of you. Congrats. It's a lovely talk. Good oration. Thank you.
Thank you, sir. Thank you, sir.
Dr. Jishan, so if there are no more comments, I will wind up the session by proposing the vote of thanks. I profusely thank Dr. Samir Dalwai for accepting the invitation and providing with an insight into how we should work in the area of child development. And thank you very much, sir. I thank Dr. Maya Bose for chairing the session. I thank Dr. Narayanan, Dr. Abraham K. Paul, Dr. Sachidanand Kamath, Dr. Jason Unni, and all the other people who have joined us and make this a big success. Thank you all and good night.
Thank you very much. Thank you.
Thank you, Samir. Okay.
Thank you very much.
Thank you, Samir. Thank you.
Thank you.
Thank you.
Samir.
Thank you so much. Waiting to come to Kerala in person, not on Zoom.
Anytime.
Yeah.
And the crab.
And the food and the crabs.